This whole episode is on shared care and shared decision making and the whole things like that with the word shared. And it's a team approach. We just got done with the World Series, and it wasn't one person that won the World Series, it was the team. And I think that's certainly the case with prostate cancer. Let me just turn to my right and talk to Dan a minute, because part of the issue that's happening right now has to do with we're finding more advanced disease. I mean, we conquered it for a long time, and now we're starting to see a rise. And do you think that's the case? And what are your thoughts from a medical oncology standpoint?
My impression is I'm seeing more patients coming in with metastatic disease frontline than we've seen in the past, and actually more primary diagnosis of metastatic disease. In other words, not somebody who's had a prostatectomy, rising PSA, and then goes on to metastases, somebody who starts off de novo with metastatic disease. And in fact, we're seeing a lot of high volume disease as well, and very high PSAs. This is just my impression, of course. I don't have data to support that, but in general, I think that we're seeing more of it.
So I've seen a couple articles that I've reviewed for journals that say that same thing. As we had seen the rate of metastatic disease fall. There was a nice New England Journal article on that, and looked at breast cancer where it sort of flatlined, and prostate where it went down, and now it's going back up. And so that means we're going to be using more advanced treatments.
Absolutely.
And that's androgen deprivation therapy, chemotherapy, some of the new drugs like Zytiga and radium and all the other drugs that are out there. So we have great drugs, but what are your thoughts about this? If we just kind of move into that area of shared care. I mean, you're sort of a urologists like to think of themselves as, sort of captain of the ship.
Right.
And I think that's good, because they're the ones that have been taking care of these patients their whole life. We share stuff with the medical oncologist and with the family practice guys. So, what are your thoughts about how we deal, going forward with a team approach? I mean, we use a team approach right now. We have nurse practitioners, we have radiologists, and yet we're just sort of in this little friction about what's the best thing for patients and how do you care for them.
Well, I think the key is communication. Communication between the primary care doctor, the urologist, and the medical oncologist. I mean, certainly we have new findings about moving some of these treatments up earlier in metastatic disease. So you have to ask the internist or the primary care doctor, is the patient fit enough to undergo chemotherapy frontline for their metastatic prostate cancer if they're high risk? Do they have urological complications that the urologist needs to take care of? Does their prostate need to be frozen when they're diagnosed with metastatic disease? Even now we're seeing that there's studies looking at the use of radical prostatectomy along with hormone therapy for metastatic disease. So this requires a integration of all different subspecialties and communication. I'm fortunate where I am at Yale, I'm in the urology department. So we actually have a de facto multidisciplinary clinic where John Kohlberg or Peter Shulam can walk across the hall and ask me a question, and conversely I can do the same. So I think that this team approach is crucial to the management and the overall well-being of our patients.
So let's just back up. I mean, a lot of patients undergo androgen deprivation therapy.
Right.
For a whole bunch of reasons. It used to be advanced disease, it's biochemical failure. We're seeing it swing back to advanced disease. Sort of when I grew up with ADT, androgen deprivation therapy, hot flashes were the side effects. Now we have hot flashes, cardiovascular, weight gain, mental changes, Alzheimer's, osteoporosis, and it goes on and on and on. And to me, that means we need to work with our family practice doctors. And I think that's a part of a team. And I think that's been left out for two reasons. One is we need to deal with the side effects. And two, sometimes we're afraid to use drugs that we should use because we're worried about, do we have to monitor things like potassium and blood pressure and things. So let me turn it over to Matt. Matt, how do we get this team together, and what are your thoughts about it, and dealing with me, dealing with Dan, and taking care of patients?
I think it's a great question. Dan, you made a great point, communication. My phone is always attached to me. If I'm getting a patient treated with something and you're worried about follow-up as a specialist, just call me. You know, we used to do that, and now for some reason we don't. I mean, we all used to be in the hospital and see each other, and some of us are
We
there.
have
and some of us
Epic
are
and
not.
all these medical
Right.
records where we send.
Yeah, we cringe a little bit with that, but you know, the reality of it is, if we communicate, we're better. If I mean, if the treating doc, if the oncologist or the urologist calls me and says, Matt, we're treating this patient, let's just say we want to give him a steroid for whatever reason, that's fine. I'll take care of it. Just send him to me and I'll follow up with it, because I do those things. That's easy. The problem that I get into is when I don't see the patient, and then they come back 6 months later with a list of medications. I'm like, where did these come from? And I need to be watching for this, and this. And the patient says, Dr. Rosenberg, I don't want to do these things without your approval. You know, we have to understand and actually embrace the relationship that we as primary care have with patients. You know, the commodity that I have as a primary care doctor is that the patients trust me. They're going to trust me with their health. So they're going to see you for surgery or you for radiation, and they're actually going to call me and say, is that okay? Can I do that? And I want them to do that. And I say, look, I spoke with Dan, I spoke with Dave. This is what we're going to do, and I'm going to make sure that I'm communicating with them, and I'm going to make sure you're okay.
Perfect. Yeah.